Well, thank you very much for the kind introduction. Thank you to Diabetes India for inviting me. It's an honor to be here, and a particular pleasure actually to be giving this talk in the Sadikot hall, since I knew Dr. Sadikot quite well. Often he talked more about cricket than about diabetes, but we had many interesting conversations. So what I'm going to talk about for the next 20 minutes is what we're seeing about the change in the profile of diabetes and the challenges, the changing challenges that this brings to people with diabetes. Almost all of what I will present is from Australia and from a range of other high-income countries, but I suspect that much of this will actually come to India. So we'll use two types of outcomes to understand how things are changing. We'll start by looking at mortality, not just total mortality, but the diseases that people are dying of, because that is a very clear marker of what serious conditions are concerning and affecting people. And then we'll look at another way of looking at the serious complications of diabetes, looking at causes of hospitalization. You know, much of this is really quite a good news story. So despite the fact that we have more and more people with diabetes, driven mainly by type 2, but also by type 1, the outcomes and the outlooks for people with diabetes, as also in the general population, have significantly improved over the last 10, 20, 30 years. This was one of my previous PhD students, Jessica Harding, put together a review of studies of mortality among people with diabetes. And as you can see, across a range of countries, there has been a fall in mortality, almost universal that mortality has fallen. But the problem with this kind of systematic review is, of course, that every one of these studies defines some outcome and some exposure in its own way, its own age group. Only males and females, 40 to 80, 30 to 70, they're all a little bit different. And so to try and address that, we put together quite a large consortium of national or subnational data sets that could address these issues about what is happening to people. And first of all, I'm showing you here what we saw for mortality. So we reached out to all of these different countries and provided them with definitions that they could apply to their own data sets, so that we were a bit more confident that we're dealing with the same thing. And once again, you see exactly the same pattern. That country after country after country, if you look here on the left, has a downward trend in the mortality among people with diabetes. In the middle panel there, the red dots, that reduces each of those curves to a single metric, the rate at which it is changing, and you can see that the annual percentage change in mortality is for every country bar one a negative number, meaning that it is falling, and you see confidence intervals far away from zero, so we can be pretty confident that this is true. Now, of course, this has happened in the context of broader falls in mortality for the general population, and so the panel on the right, the blue dots, is the standardized mortality ratio, which compares those with diabetes to the rest of the population or to those without diabetes, and not all of them, but many of them are also to the left, in other words, in negative territory, meaning that the difference between diabetes and the general population was narrowing, at least in some countries. So some really positive things to see there. Of course, this is total mortality. It's the easiest thing to count, but it's hard to take away messages from it because you don't know what types of diseases are contributing to it. So in a more recent publication that is just coming out in Lancet Diabetes and Endocrinology, we've looked in a more focused way at cardiovascular mortality. The panel on the left, people with diabetes, the one on the right, people without diabetes, again, country by country, for myocardial death from myocardial infarction, death from stroke, death from heart failure. And what you see is in the population with and without diabetes, there is uniform falling for MI and stroke. The slightly worrying thing is heart failure. particularly for people with diabetes, where we're not seeing that reduction. It's a little bit uncertain. Some of them even seem to be going up, and it looks a little bit worse for people with diabetes than without diabetes. Now, we have to recognize that heart failure is a more difficult condition to be confident of in death certificates, but nevertheless, an indication that what the benefits that we're seeing for atherosclerotic cardiovascular disease may not be there for heart failure, despite the fact that over the time period that we're looking here, going from 2005 to 2020, there has been, at least for part of that period, the introduction of SGLT2 inhibitors, which should have had a benefit on heart failure. Now, the other thing that one frequently hears about diabetes is that most people with diabetes, 70% of people with diabetes, some figure like that, die of cardiovascular disease. That cardiovascular disease is the #1 killer of people with diabetes. That really isn't quite true, at least anymore. As you can see from this is another paper that hopefully will be coming out soon, again from this large consortium. So this shows the two most common groups of causes of death: cancer and cardiovascular disease. Cancer in blue, cardiovascular in the orange. And you'll see that, first of all, almost no country ever, at least going back over the last 15 or 20 years, ever reported that the majority of people with diabetes were dying of cardiovascular disease, even though it might have been the #1. And that now for some countries, cancer is the most common cause of death for people with diabetes. An indication that there is more happening to people with diabetes than just the traditional macro and microvascular complications. And we're not the only ones to have done this sort of thing. Here's a paper from England looking at the time period from 2001 to 2018 and looking at proportional causes of death. So for every year, take all the deaths and divide them, what percentage is due to cardiovascular, what percentage is due to other things. And the blue at the top is cardiovascular, and you see how over time that narrows. So a smaller proportion of people dying from cardiovascular disease. And by the end of that, by 2018, as you can see, it's around about 30%. So 30% of all deaths in people with diabetes in England in 2018 were due to cardiovascular disease. The other major player in there is red, that's the cancer, but the one that's expanded, that has taken up the slack, as it were, for the fall in cardiovascular deaths is dementia. So a big rise there in dementia as a cause of death. These are similar kind of data. Back to Australia now, tracking it from 2002 to 2019. Again, we're looking at proportionate causes of death. So for every year, it has to add up to 100%. So where you see on the left the falling proportion due to cardiovascular disease, something else has to go up because it still has to add up to 100%. We're seeing a slight rise in renal, a slight rise in some of the other complications, an early but then not sustained rise in cancer. But the big thing that rises is that category other. That's where the deaths from cardiovascular disease are being replaced. So what's happening there? So if we look at that, the top graph, you see dementia as being, when we look into other, it's dementia that is rising. Is that because the population is aging? Well, partly. But if you look at the bottom panel, this is where we only look at people aged 70 to 79. At the start of the observation period, the mean age of that population was 75.4, 75.3 at the end. So aging is not accounting for this. And yet we see this rise in dementia. So it sounds like the age-specific risk of at least dying of dementia is increasing. Some of that is probably due to changes in the way that people complete death certificate forms and a greater preparedness to put dementia on there. But it's a real signal that dementia is a major concern and a major threat for people with diabetes. Now, we don't have much data from this region. What we can see, this is an analysis of the PURE study, the South Asian populations that took part in PURE. And you can see that, again, this is percentage of deaths, that cardiovascular disease, and this is in the general population, is the #1. But it's the #1 at about 35, 36% of all deaths. There's a lot of other things happening that is leading to death, and a lot of potential that that is happening more frequently in people with diabetes. Now, the second part of this that I wanted to focus on, we've looked at death. So what is the other kind of metric that we can use to measure serious consequences and complications of diabetes, and that's hospitalization. And we've looked at this again in a lot of national Australian data, and we see again some improvements. We see heart failure coming down over this period from 2010 to 2019. We see MI falling much further. Heart failure on average fell by 0.8% per year, MI by 1.7% per year. But no fall, in fact, an increase in amputation, rather worryingly. Hypoglycemia also went up, likely as we saw increasing aggression in the way in which we're treating diabetes. Sorry, hypoglycemia went down, and we're probably using less insulin. We get other things to use. Hyperglycemia going up. But the important things there is that we're seeing the same signal in hospitalization for MI as we're seeing in mortality, a lesser signal for heart failure. Now, the other complication that can be looked at, again, at a national level in many countries is renal disease, because we, like a number of other countries, have national registries of end-stage kidney disease, essentially renal replacement therapy, dialysis, or transplantation. And this is the second paper in which we found that over time, end-stage kidney disease was increasing. Now, this was a concern. It was a surprise and a concern. We would have thought that as we're controlling blood glucose better, as we've got better use of ACE inhibitors, ARBs, this goes up to 2020, so we've got 7 years since SGLT2 inhibitors were introduced, you might have expected to see an improvement. However, when we adjusted for duration of diabetes, the effect turned around. So overall, the incidence of renal replacement therapy and death from kidney disease was going up, but that was going up because duration of diabetes was increasing. Now, when you think about what that means for healthcare, that means, well, maybe we're actually doing a good job. We've got more people with long duration diabetes, therefore you're going to see more complications, but the actual individual person risk at any point in time is going down. And this makes a really important distinction between two concepts that we use in epidemiology, being burden and risk. If you're running the hospital service, you're interested in burden. How many people are going to need my dialysis services, my hospital beds? The burden of disease is going up in Australia. But the individual person risk, the likelihood that a person who has had diabetes at the age of 70 for 10 years, let's say, that they will have end-stage kidney disease has gone down. So we're kind of doing a job in managing people. The problem is that we've got more people with diabetes and more people with longer duration. Now, we've also looked more broadly at hospitalizations, because as I hinted before, there's a lot more happening than just the micro and macrovascular complications. So here we plotted pretty much for every ICD code for hospitalization, the risk between those with and without diabetes. And you can see those in the top right-hand corner are all of those conditions for which there is statistically significant evidence of an increased risk in people with diabetes. Now, we'll come on to what some of those are in a moment, but they're colored according to the broad category of being traditional complications and comorbidities of diabetes, orange being the emerging, and blue, other. Things that we have no reason to think are connected to diabetes. That top right-hand corner is full of things that are not green. There's plenty of green there, but there's a whole bunch of other stuff that people with diabetes are being hospitalized more frequently for than people without diabetes. And it's difficult to look at large numbers of those, so we sort of took out the top 10 for men on the left and women on the right. When you look at the top 10, it's a bit of a surprise. The ones that account for the most excess hospitalizations are not completely explained by traditional complications. And so if we highlight the traditional ones there in green, as you can see, well, for men, they account for half of the top 10. For women, only a third. So what about those others? Here are the orange ones, the sort of the emerging complications, the ones that we think we've got some evidence for. So we're seeing mental health issues becoming prominent here. Infections that perhaps we don't traditionally associate with diabetes, for example, like pneumonia. But what have we got in other? Look at that. We've got 2 out of the 10 for men, 3 out of the 10 for women are in this other group. And the one that struck us as being the most surprising was iron deficiency anemia. So that is the third most common cause of excess hospitalizations in men and the single most common cause of excess hospitalization in women with diabetes. Now, these are mainly people being hospitalized for things like iron infusions, for investigation of iron deficiency anemia. It's not quite as bad a thing as being hospitalized for an MI. But why are we seeing so much anemia? So we've looked into this further, and whilst there have been a number of reports over the years about an association of diabetes with anemia, it really hasn't been crystallized. And so what we did is we looked elsewhere, and we got data here from the UK Biobank, on the next slide also from the US NHANES study. So you look at the UK Biobank and at baseline categorize people according to diabetes status, and then look at what happens over the follow-up over the next 15 years or so, and look as it were through their medical records, you see that for every type of anemia, people with diabetes are more at risk of developing that anemia than people without diabetes. Most prominently seen for iron deficiency, and you can also see these numbers at the bottom which indicate the total number of people who had anemia, and iron deficient anemia is the largest contributor. There's actually unspecified on the right, which is even larger, and that's probably also mostly iron deficiency. Now, one of the reasons that you can get this is that you say, well, people with diabetes, they're being checked for all sorts of other things, and so, of course, they get diagnosed with anemia. So we also looked at the baseline data from these studies where everybody had a blood count, and that's from the UK Biobank and from NHANES. And in support of this connection with anemia, and particularly with iron deficiency, we see that all of the metrics that go along with iron deficiency are worse in people with diabetes. Lower hemoglobin, lower MCV, lower mean cell hemoglobin, and mean cell hemoglobin concentration. So there's something here that is influencing red cell maturation, some component which is affecting, leading to anemia across a range of different types. So as we come to the end, this is now one way in which we think of the complications of diabetes. Not just these traditional micro and macrovascular, but a whole bunch of others. However, not everything is emerging. We looked at hospitalization in a slightly different way. What I've shown so far is the incidence of hospitalization. Every hospitalization counts once. But you can also look at things like bed days, how long people spend in hospital. There's a huge difference between being in hospital for 1 day for an iron infusion or a colonoscopy and being in hospital for 2 months for a foot ulcer. So this looks at excess bed days, and what we see for excess bed days is that in fact foot complications are responsible for more excess bed days than any other condition. Any other condition. So some of the traditional ones are still causing a lot of trouble. So let's end with just thinking how this might look in the future. We're going to have an older population, longer duration of diabetes, more obesity. That's likely to lead to more dementia, more heart failure, more physical dysfunction, the longer duration leading to more microvascular, as we saw with renal disease, and obesity is going to link to liver disease, heart failure, and atrial fibrillation. On the other hand, we've got drugs that might be opposing this. So we might see less renal disease, less heart failure, less MI, less stroke for the reasons here. How do we put these together? Just as a final slide. This is my guess for the future. Certainly the guess for my future for Western high-income countries, maybe a little bit further into the future for India, but I think it's coming. So I suspect we're going to see more physical dysfunction, more retinopathy, more foot problems, more liver disease, more AF. Renal disease and heart failure, stable, maybe going down. MI and stroke, that will continue going down. But the other major players here, infection, mental health, I think we've got no idea which way that's going, and they may constitute a major challenge in the future. Brief conclusions. We're seeing more diverse complications of diabetes, but the risk and incidence of developing those for many individuals will fall whilst the burden is rising. And we're going to see a changing profile over the next few years. And with that, thank you for listening, and just